session or webinar. The session for today, we will talk about the different clinical aspects of abutment selection using the different abutments and the way of connection. I will introduce the clinical aspects of abutment selection, what will be the important parameters of the clinical case that we can rely on when we decide which abutment to use. Of course, the abutment selection is the most important aspect of implant-supported prosthetics. I will talk about I will show some cases, clinical cases that will show the strategy of decision-making, the workflow of the restorations, including the immediate implantation and immediate loading, with emphasizing the important aspects of the aesthetic zone and the limitations that we can face restoring the posterior area, especially when we have limited height and mechanical forces, and the decision to use screw-retained or cemented restorations. We will start showing some clinical aspects, and of course, if there are any questions, you can just ask, you can send by the chat, and of course, I will be more than happy to answer. The first case, I will show that the abutment selection can also be influenced by the decision what to restore using the restoration of a single tooth or a multiple unit restorations. Of course, it will change the decision which abutment to use and what connection to use, which can be a screw-retained or cemented restoration. The parameters that can influence the decision which abutment to use, mainly the tooth location, the angulation of the implant, the peri-implant gingival level and shape, the interdental space, the intermaxillary space, the material of restoration, implant platform, and of course the mechanical forces that can be implied on the abutment. The first case, it's actually a small case of restoring deciduous tooth that was not replaced by permanent tooth, and you can see that we have impacted tooth, and we can see that we have missing molar. The single unit restoration and multi-unit restorations and full arch restoration, of course, we have different attitude of restoration. The tooth location can influence the shape of the abutment and the restoration. We have the restoration of the anteriors, we have the premolars, and we have the molars. And in each replacing tooth, we have to decide which abutment to use. In this case, we have congenital missing of laterals, and accordingly, we have also migration of teeth, you can see that we have at the left side of the maxilla, we have limited space for restoration, and we have also over-eruption of the posterior molar. With the extrusion of the tooth, we have also extrusion of the gingiva. And when we want to design the treatment of this case, we have to take into consideration the level of the gingiva, and we have to make a crown lengthening of the molar in order to have a good anatomy and a good fair effect on the restoration of the teeth. The implant position also influenced by the interdental space and the height, because we need also to make enough retention for cemented restoration in this case. So we connect the abutment to the implants according to the angulation. We make adjustment of the height, and finally make the temporary restoration. And we can see that we have a restoration that converts the laterals into canine, and we have the missing teeth restored by implant-supported prosthetics. So the abutment selection in this case can also make a difference with the interdental, influenced by the interdental space and the restoration intermaxillary height. The next case is actually deciduous tooth that we're missing, and we are supposed to replace this tooth because of mobility. So we try to make the restoration immediately at the day of implantation. This is the impacted submerged tooth extraction. We have to equalize the height of the bone, and we can make the implantation at the same day for extraction, because actually we don't have that much of socket, because we have very short roots. The temporary restoration, we can use the temporary abutment for screw-retained restorations. We can use also the standard abutment that can also be adjusted by making some retentions and making the immediate restoration screw-retained. The advantage of screw-retained temporary abutment is very big advantage in this case, and in any case that we are making temporary restoration, because the screw-retained, we have much more control on the biological area and the stability of the abutment and the restoration, and we don't have any excessive cement, so it can be advantage in any case of immediate implantation and restoration. For the final restoration, we have to copy the emergence profile of the temporary restoration, and in this case, we can use flowable composite at the stage of impression taking, and we can copy the area of the gingiva, and according to that, we can select the width and the emergence profile of the abutment in order to have a good contour of the final restoration. In order to copy this shape of gingiva, we have to take it immediately after taking out temporary restoration in order to stabilize the gingiva, because at the moment we take out the temporary restoration, we will have some distortion of the gingiva, and that's why we have to take the impression immediately after the temporary restoration is removed, and this can be also managed much easily when we use the screw-retained temporary restoration. This is the final result. We can see that we have a good emergence profile of the crown, and we have a good stability and osseointegration of the implant. At the premolar area, we have the interdental space that we have to restore, and we have the buccolingual aspect. The buccolingual aspect is important in order to decide where to place the implant. And when we try to make the implant positioning, it will be much more easy to place the implant actually at the palatal aspect and the palatal root socket, where we have enough bone and we have to make the emergence profile of the temporary restoration similar to the natural tooth. This can be easily done when we use temporary abutment and screw retained restoration when we have the emergence profile of the premolar tooth. In order to do that, we have to make a hole in the temporary crown, and actually we have to make sure that no acrylic material or composite will go inside the hole in order to easily retrieve this temporary restoration. And of course, we have to make it out of occlusion and without any eccentric movement. The final restoration can also, we can see that we have the exact shape of the gingiva, and we have a good integration of soft and hard tissues around the implant and restoration. Another case, treating premolar, in this case the second premolar in the maxilla, we can see that we have very deep fracture of the crown, and after the extraction it's important to be sure that we have a traumatic extraction procedure in order to keep the buccal plate intact. When we have a problem with the buccal bone intact, we have to make augmentation procedure. In most cases that we can preserve the buccal plate, we can make the implantation and the restoration without the need of any augmentation procedures. The preparation in this case, when we have just one root, is supposed to be longer than the length of the root, and as possible palatally, in order to have a good bone support after osseointegration. The implant can be stabilized by the interproximal bone and the apical bone. So we have 3 points of stability. We have the proximal bone and the proximal area of the implant, and we have the apical positioning of the implant that can also contribute to the stability of the implant, and we can rely on this implant to make the immediate restoration. In order to be sure that we have a good result, we have to use the torque range in order to be sure that we have at least 35 Newton per centimeter. The temporary restoration actually can be done chairside on the mouth using abutment. We can use regular abutment with cut height, and we can make adjustment of the excessive height of the abutment extraorally, then make some retentions on the abutment, and we connect back the abutment, and we take pre-customized crown and make small hole and rely this crown on the abutment, and that's the way that we can convert the abutment to screw-retained abutment. And you can see that we can make the contour of the gingiva extraorally, and we can reshape the abutment and the crown as a whole piece. This is the advantage of screw-retained temporary restoration. This can be screwed in the abutment, and this will contribute to the integrity of the soft tissue, and according to the shape of the abutment and crown, we can achieve a good healing of soft tissue. What you see here is after the healing, we can adjust the abutment according to the interdental space with anti-rotational element, and we can make the PFM according to the shape and anatomy of the missing tooth. This is the final result. In the aesthetic area, in the anterior area, we have to be much more careful with our decisions. It is important to evaluate the mesodistal and buccolingual aspect and dimensions of the socket in order to decide which implant to use and which diameter of implant to use. It is important to know the limitations, especially when we have adjacent teeth. We have to leave at least 1.5 millimeter of safety zone between the implant and the natural roots, and we have to place also the implant shoulder, the platform, about 5 millimeter from the CJ, from the contact point of the adjacent teeth. This can show the good integrity of the soft tissue, the papilla reservation, and of course we can get a very good stability of the restoration and the soft tissue, which is something that have a very big influence on the aesthetic outcome of the restoration. When we have normal space of the restoration, we can use the standard abutments, and in some cases we need to use slim abutments in order to cope with the limited interdental space. And when we have a molar area, we can also select a wide abutment in order to have a good emergence profile of the restoration. In this case of molar area, we can use some abutments that have a good emergence profile that can be suitable for molar area, and we have abutments that already prepared for this purpose of with the cuff height, and we have also the possibility to use abutments that can be prepared at the lab in order to have custom-made abutment restoration preparation. In limited interdental area, we can use the slim abutments in order to have a good interdental space for emergence profile and for maintenance, and in order to have a good stability of the soft tissues around, because too close implants, too close abutments can make some recessions, and we can have limited aesthetic results. The anterior area of the mandible can also be challenging when we have limited interdental area. We are talking about few millimeters that can be the space that we can decide which implant to place and which abutment to use. In these cases, we can see that narrow implants can be a good solution in order to be at the safe distances between the adjacent natural teeth. And according to this implant, we can also use slim abutments in order to have a good retention and maintenance of the anterior teeth. This is the abutment preparation and the final crown restoration. The implant platform can also influence the decision about which abutment to use. We know that the platform switching is actually a concept that is widely accepted today in order to isolate the bone and soft tissue from the friction area. That's why the abutment is a little bit narrower than the platform width. So the friction area and contact area between the abutment and the implant is far away from the abutment. That's the way that we can achieve also vertical biological width that can also isolate the soft and hard tissues from the mechanical forces that can be implied on the restoration and finally to the implant. So this is supposed to be a good solution in order to stabilize the soft tissue and to avoid excessive resorption of the bone. The advantage of this conical connection can also be seen in the aesthetic area that we can use these specific abutments to have a good emergence profile, especially when we have limited width of restoration. The limited space can also be seen in when we have orthodontic treatment and we have closeness between the roots, and we can see that this is also a case that we have to cope with, especially when we have limited distance between roots. So we can use this narrow implant platform and conical connection in the anterior area of the mandible. And of course, when we have in the anterior area, when we have limited bone width, it can also be used in order to restore the missing area without the need of augmentation. In the case of the anterior area of the mandible, we can see that we have two laterals, and according to the X-ray and we can see that we have limited width of gingiva, and we need to make fixed restoration. So the treatment plan was actually to extract the laterals and to place two implants in the lateral areas. For the narrow implant, we need to make just one drill, about 2 millimeter. It's very narrow body implant with a conical connection that can also be advantage in the abutment shape and restoration. The implants were inserted according to the protocol of drilling, and finally abutments were also connected with a suitable cuff height in order to make the maintenance of the case easier, and the temporary immediate restoration was cemented on the abutments, of course, out of any lateral or occlusal contacts. After osseointegration, we can see the integrity of the soft tissue. These are the abutments that were placed at the same day of extraction. We can see that we have some dehiscence or some recession around the abutment, but still the implants were covered with bone, and we have a good soft tissue integrity. In this case, we need just to replace these abutments to custom-made abutments in order to have a good shape and anatomy of the restoration. At the posterior area, where we have enough inter and intermaxillary distance, we use the standard abutments in order to have a good anatomy of the posterior molars. For the impression taking, we can use the snap-on for closed tray and the closed tray of the anterior conical hex connection in order to take the impression with the gingival height and shape. The closed tray impression using the snap technique, where we have the plastics that were connected to the abutments on the posterior implants, and the anteriors we have the closed impression that we can connect the abutments and we make the working model. After taking the intermaxillary relations using rims, we can select the abutments. In this case, the abutments were selected in the lab, and according to the parallel and pathway of insertion, the technician will select the abutment, and we will make the preparation of the abutments to have a common way of a pathway of insertion of the posterior area, and for the anteriors, for the bridge that restores the anteriors. So the abutments at the anterior area were slim abutments connected to slim implants, and the posterior implants were standard platform, so the abutments were suitable for molar and premolar area. After the fabrication of the abutment, we have the metal frame that has to be checked in the mouth, and of course we need to make the registration of the centric relation and intermaxillary height again in order to be sure that we have sufficient clearance for the porcelain building. and this is the final restoration. We can see that we have a good integrity of the soft tissue, and we have for follow-up of this case of several years, and we can see that we have almost no recessions or resorption around the cervical area of the abutment, especially when we use the platform switching. The platform switching, you can see that it was used at the anterior because we have a conical connection, but we can use it also with the standard abutments, but we use a narrower abutment. This will also contribute to the integrity of the bone of the posterior area. So platform switching is an advantage, especially when we have a conical connection. And even if you use the internal hex connection, you can also select a narrower abutment profile. And this will also give us advantage in the stability of the gingiva. The angulation of the implant also important, and we have several designs and angulation of abutments that can make the restoration design much easier. We can use the standard abutments that we don't have to commit to the gingival height. It can be prepared extraorally in the lab according to the gingival cuff, and we can also use the anatomical abutments. You can see that we have also different colors. We have the yellow color of the abutment that can be also useful in the aesthetic zone especially. The anatomical profile of some abutments is important because it will support the soft tissues, especially when we have to restore this abutment between the adjacent natural teeth, and we want to preserve the papilla. So this shape will preserve the soft tissue much easier, and it can be also easy to make the restoration because we have a shoulder of the abutment that can also give space and freedom for the technician to make the restoration, especially when he uses a multi-layer porcelain materials. This will give more aesthetic results when we have more thickness of the restoration. The screw-retained cement, the screw-retained restoration can also be a good solution in many cases, especially when we are talking about the limited space of restoration at the posterior area. And actually, it can be done with two different concepts. The first concept will be actually making the whole crown with the abutment that will be inserted into the implant via the hole that can make the entrance of the and access to the screw, and this crown is actually screwed in to the abutment. This will make no need for any cementation, so we don't have excessive cement that can influence the health of the gingival around, because we know that the excessive cement has a bad influence on the soft tissue. And of course, with cemented restoration, we need to make the screw of the abutment first, and then we have to cement the abutment to the crown to the abutment. The screw-retained restoration is indicated actually in many cases. There's some clinicians that prefer to use this type of retention as a standard. Of course, the screw-retained restoration concept is not new a concept. It was used widely as the first steps that we started using the implant supported prosthetics. But today we know that there's some limitations of this technique, so we recommend to use the screw-retained restorations in single implant restoration in order to have the ability to retrieve the restoration and make it easy to maintain the implant-supported prosthetics, especially if we have screw loosening, so it will be much easier to take out the abutment and the implant together and make tightening or rescrewing the restoration back on the implant without need to retrieve the crown. This mission will be much more difficult if we have cemented restoration in a single implant. The other indication for the screw retained restoration is the limited occlusal height. When we have a very few height of restoration, we need to use a much stronger retention technique, which is the screw retained restoration. In another case, we have a cantilever, so it has a very big load on the abutment, so we need a much more reliable connection, so the screw retained will be the choice. Another indication is when we have extreme angulation of the implant, so there's a problem taking impression of such a situation that we have angulated implants, so we cannot make implant level impressions, so we need to use different connections, so we use the screw retained restorations. And when we have limited number of implants, that also can be support for fixed prosthetics, so we need much stronger connection, and this because we have much more mechanical forces in the implants and the abutments. The choice of making single restoration screw retained actually is because we have the advantage of the retrievability. If we have a situation that we have a loosening of the screw of the abutment, there's no problem to screw it in case we have abutment screwed with the crown, and we can prevent loosening of the screws when we use a brand new screw in the case that we want to connect the final restoration. And the most important thing is to connect the screw to the abutment and the implant using the recommended insertion torque, which is about 30 Newton to centimeter, according to the manufacturer recommendations. And if we have a loss of abutment retention, we can use the screw retained in order to have maximum retentions, and there's no problem of losing the retention of the crown. The implant angulation can influence the decision when to use the screw retained or cemented restorations. The way of correction of the implant position can be used easily when we use angulated abutment for cemented restoration. In order to use the screw retained in single restoration when we have angulated implant position, can be more problematic, so the implant position has to be a little bit lingually, like in this situation, in order to make it easy to make screw retained restorations. When we have to go with the same axis of the implant and we have angulated implant, the screw will be, the axis of the screw will be too buccally, and this can influence the aesthetic outcome of the case. In some cases, we have to make it screw retained. We can correct the angulation of insertion using special abutment called angulated multi-unit abutments. As a general, if we have angulation of the implant about till 25 degrees, it is recommended to use the cemented restorations. It will give us much more aesthetic result because there's no access hole in the crown, and we can make the whole anatomy without any limitations. If we have more than 25 degrees of angulation, we can use the screw retained restoration technique, but we need to be sure that the implant is positioned palatally enough in order to have a good access to the implant without harming the aesthetic outcome. If we have more than 25 degrees of angulation, we need to use the multi-unit abutments and the angulate multi-unit abutments in order to have a good retention and sufficient aesthetics. This is a clinical case that you can see here. We have a limited space of restoration at the molar area. This is because we have over extrusion of the posterior area of the maxilla and the mandible. In the left area of this case, you can see that we have over eruption of the left molars, and we have resorption of the left mandible. So in order to have a good space and sufficient space for restoration, we have to make pre-surgical preparation of the maxilla at the right side and then the left side. So what can we do in this case? Of course, because we have a good periodontium of the anteriors, there's no indication for vertical dimension increase. So we have to make all the space gaining just by preparing the posterior area of the maxilla. So there's no indication in this case for VD enlargement because we have a good periodontium of the anteriors. We can make extraction of some of teeth when we have severe over eruption. We can make a crown lengthening of some of the over extrude teeth, and we can make in moderate cases gingiviectomy in order to have a good shape and height for the clinical crowns of the antagonist teeth. And the maxilla, in this case, when we have more bone than we need, we can make bone osteotomy, and there's a possibility to make orthodontic surgery to increase the height, especially when we have orthognathic problem that we can solve by orthognathic surgery, especially in severe cases. In most cases, there's no need to do that. We can use also the screw-retained restorations because we need much less height of iner-occlusal area for screw-retained prosthetics relatively to the cemented restoration. So one of the tools that we can use in order to cope with this limited area of posterior intermaxillary space is using the screw-retained prosthetics with one of the pre-surgical procedures. The use of screw-retained restorations can also be indicated when we have more load at some of the implants. This can be seen in the concept of cantilever. So when we have a cantilever, we can see that we have more load on the implants, so we need to use more reliable connection, and the screw-retained restoration can also be a good choice in most of these cases that we have a cantilever, especially when we have limited number of implants. So in order not to lose the retentions of the restoration and to have as much as possible for having the forces on all the implants as much equal as possible, the screw-retained restoration can be a good choice in most of these cases. We know that the screw-retained restoration is being used widely at the last years, and this is actually because of the use of specific techniques like Orin 4 and Orin 6 techniques that can be used as a standard as according to these protocols just for screw-retained restorations. The other reason of the increase of the use of the screw-retained restoration actually because of the increasing demand and use of the CAD/CAM technologies of implant supported prosthetics. And we know that the digital restorations need to be used, need to use the screw-retained technique because all the restorations are made virtually, and there's no abutment that we can make it with cementation. Just in few cases that we can make custom-made, also digitally designed abutments, and the crown on these abutments, it can be also used as it's cemented. But in most cases, the digital restorations are actually screw-retained restoration. That's why we have much more use of the screw-retained restorations. The cemented restoration actually has a lot of advantages. Mainly, it improves the aesthetics and anatomy of the restoration because there's no need for holes, and we can make the abutment selection and the angulation correction can also be used in order to have a much more anatomical shape, and aesthetics is actually the main advantage of the cemented restoration. And if we just manage to make a preparation of several implants and abutments, we can reach passive fit restoration. So we have two main advantages of this cemented restoration. The first one is the aesthetics. We have no holes or no limitations of the access of the implant and the angulation of the implant. It can be managed easily by selecting a good abutment, angulation, and shape. And we have the passivity of fit, and there's a cement that can also absorb some of the overload, and it can also manage the sometimes some misaccuracy of the fitness of the fitting of the restoration of the abutment. So we can see that the cement restoration is much more passive relatively to the screw-retained restorations. And the screw-retained restorations have a very wide advantages, but the most important thing in the screw-retained restorations is that we don't have excessive cement. Because we have the excessive cement as a problem and the major cause of peri-implantitis, and in order to avoid the excessive cement, we actually make the restorations screw-retained, and this can be also a big advantage at the provisional or the temporary restorations in order to shape and make the soft tissue arrangement much easy to control. And it can also give us the ability to retrieve or to take out the restoration at any time without making any harm or any damage to the restoration or to the implant, especially when we have some temporary period or some healing time that we have to wait and to be able to control the case in several stages. The cemented restoration workflow, there's actually two techniques. One is taking the abutment and connecting to the in the mouth of the implant preparation and make the impression from the abutment level. This is the much less recommended technique because we don't have a good control on the finishing line and on the accuracy of the abutment shape. The recommended workflow of cemented restoration, actually, we recommend that we take impression from the implant level using the open or closed tray, and then we select the abutment on the working model. And actually, the lab can also make that easy for us, so it can be used as much more reliable technique in making cemented restorations. The screw-retained restorations, if we have some moderate angulation of the implant, we can make the impression from the implant level using the open or closed tray technique, and then we can make the final restoration using the casting or the milling technique. And we know that the CAD/CAM and the digital restorations technique can also have a big influence on the final accuracy and stability of the restoration. The abutment selection in this case of screw retained, when we have impression from the implant level, is actually much easier, and we can use the castable or the castable abutment that has the milled base. On the other hand, we can make the whole process of screw retained restoration using the abutment level. So we connect the multi-unit abutment, which is the platform shifting from internal to external connection, and then we take impression to the abutment level. The multi-unit abutment actually makes the internal external connection, which is much easier for a pathway of insertion of multiple units, and it can also raise the level of connection between the abutment and restoration for the level that we can maintain, and we can make a good support for the whole work, even and make it much easier to clean and to maintain after the finishing of the work. And then we can also ask the technician or the lab to make the restoration using the CAD/CAM techniques. And in most cases, it can be used using a special abutment called K-base abutments. This abutment is used actually in order to connect the restoration to the implants, and it can be also a possible way to do that. Instead of taking the impression from the abutment level using the standard techniques of impression taking, we can make it also by using digital. They are called also burnout sleeves, because we convert these plastics into metal, and these abutments actually can be modified at the final shape of the desired abutment. So we can make a custom-made abutment according to the emergence profile, to the height, and finally it can be used for the cemented restorations or for the screw retained restorations. In order to make this abutment much more accurate, we can use the castable burnout sleeves with the metal base that is manufactured according to the standards of the factory, instead of casting the whole plastic into metal. And we can see that when we use the whole plastic abutment for castable abutment, we can see that also the platform area connection is actually not that accurate, because it will be influenced by the abutment, by the metal casting and technique procedures. The implant connection and the abutment is very important, and in order to have a very good integrity between the implant and the abutment, we recommend to use the plastic sleeves with the with the chrome cobalt base, in order to have the accuracy of the fit of the hex, and of course we can manage to modify the shape of the abutment or the crown in order to have a good shape and a good connection between the abutment or the restoration and the implant. This is the case when you use the whole plastic for casting, and this is the case when we have the castable abutment with milled base. This abutment has a big advantage, because we have actually a milled base that is much more accurate than the casted base, and this can also be seen that we have less complications after delivery of the work, less screw loosening and less fractures, and much less bone resorption about the implant, because we have a good fit and we have the equal tolerance between the abutment and the implants, much more than the full crown castable sleeve. This for single unit restoration, screw retained, we have a different way of doing that using special multi-unit abutment. This abutment has to be with anti-rotational element in order to have the screw retained restoration fit on the implant and with anti-rotational element. So we use two heads, one inside the implants to convert to the internal to the external, and we have the external burnout sleeve fit area in order to have a good stability without any rotational movement. And this can be used in order to make a single unit restorations for retained, actually using the intermediate part, which is the multi-unit abutment. We can use it directly to the implant, and we can use it using the multi-unit abutment. The advantage of the multi-unit abutment is that we can raise the height of connection from subgingival area to the area that we can easily maintain, and we can give a good emergence profile of the restorations. The material of restoration, with many materials that we can make the restoration, we widely use the metal base, and for that we have the Castable abutment. Today, especially when we have the CAD/CAM technologies, we can use the zirconium or Emax or lithium disilicate material in order to design and manufacture a special abutment shape and full crown screw retained restoration. These materials have a very good aesthetic results and, of course, biological advantage on any other kind of restorations. The abutments can be available for the conical connection and for the internal connection. For the conical connection, we have advantage that we have naturally built platform switching, that all the area of connection is far away from the surrounding bone. So this will influence the stability of the soft tissue and hard tissue around the implants. And we can see that when we use the Castable abutment on the implants, we can use this technique of two pieces of abutments. This part will be casted and will be modified by wax, and then will be casted. And we have the base that will be connected to the implant, and one screw that will connect the two pieces together. This will ensure that we have a good accuracy between the parts, because we have milled base on the implants, and we have the castable element that can be converted to the crown as the final framework of the restoration. This can be used mainly for the metal frame or chrome cobalt restorations. The cantilever that we can also use on implants, something that is used also in architecture. We can see that cantilever is used in many cases, especially when we have a limited height of bone at the posterior area. So we have two limitations. We have actually the angulation of the implant, and we have the cantilever. So this finite element shows what will be the influence of each parameter, the angulation of the implant or the cantilever. And what we can see here in this diagram is that even if we have straight implant or angulated implant, we have still no significant difference between the angulations of the implant at the cervical area. That means that it doesn't matter what angulation has the implant, the stress on this implant will not influence the surrounding bone stress, but this, of course, can be concluded just when we have splinted implants. This fact actually is not right, and when we talk about single implant, it will be actually a good conclusion when we have splinted implants. So when we have splinted implants, the stress when we connect the restorations together, the stress on the cervical area when we have angulated implants is not actually increasing the stress in the bone around the implant cervix. What happens when we have a cantilever? When we have a cantilever, actually this will elevate the load on the cervical area significantly. So you can see when we have the cantilever, the stress actually has a very high value. And this means that we have, when we have a cantilever, this will cause overload on the implant. But when we have angulated implants, this actually, when we splint all the implants together, this is not being a risk factor. So the concept of using the cantilever is actually to make the implants as angulated as possible in order to make the cantilever as short as possible. This is the case with extreme resorption of the mandible. You can see that we have very limited height at the posterior area of the mandible. And we can design a restoration, fixed restoration, when all the implants are placed at the anterior area and we have short cantilever at the posterior area. We start by using the old denture in order to make just a sign for the area that we can place the implants, which is the implantation area. It's about 20 millimeter from the midline of the mandible. So we can use the old denture in order to just make a guideline for the implantation insertion. And after the flap was raised, all implants were connected according to the window of the denture, and abutments were connected. Of course, these abutments are for cemented restoration, but we can easily convert these abutments into screw-retained restoration. And in all cases that we have angulated implants or cantilever, it is recommended to use screw-retained restoration. First step, we make some mechanical retentions on the abutments. Then we connect the abutments with acrylic. And finally, we connect the denture to the abutments in order to be sure that all the abutments will be insured inside the acrylic and no movement can occur in this stage, because we need the axial accuracy also, not just the inter-implant accuracy. So all the implants were connected to the abutments, all the abutments are connected together, and it was all connected to the denture. Finally, we can convert to the removable denture into screw-retained temporary restoration that is fixed on the implants to the implant level. This is the post-op immediately after the insertion of the implants and the restoration. The X-ray shows that we have a good insertion and positioning of the implants, and we have good connection between the abutments and the implants. It's very important to make this double check to see the implant position relatively to the nerve and to see that the abutments are firmly connected to the implant. After the osseointegration is achieved, we take impression from the implant level, and then we use the old denture, which is screw-retained, in order to take all the parameters that we need for the final restoration, which are the vertical dimension, the occlusal relations, the occlusal plane, the teeth size, and the gingival display. These parameters were fine to the patient, so there's no problem to take this information and copy this information for designing of the final restoration. The way that we take this information, we actually make the buccal index of the temporary restoration, and we make another setup of teeth in order to verify the occlusal height, the vertical dimension, and the centric relation. And then, according to the new setup of teeth, we make the final restoration using the multi-unit abutments to convert the internal to external hex. And then we use the burnout sleeves on these abutments and make the metal frame screw-retained restoration using the multi-unit abutments to the implants. These are the multi-unit abutments. This is the metal framework. And this is the final restoration, screw-retained restoration with bilateral cantilever. The restoration is connected to the implant via the abutment, the multi-unit abutment. This can also be achieved easily. There's no problem with angulation, and there's no excessive cement, so that we can manage the soft tissue much easily. This is the final restoration. The opening of the screws is plugged with composite. And this is the final restoration. You can see the occlusion and good integrity, and we have to leave enough space for maintaining this case using some irrigation, mechanical rinsing, in order to be sure that we have a good biological maintenance for the patient for long-term survival of this work. This is the X-ray that can show the good integration of the abutments to the implant and of the restoration on these abutments. When we have angulation and some tilting of the implants in the for restoration, we can use special multi-unit abutments. These multi-unit abutments is called angulated multi-unit abutments. This case was treated after the implants were integrated. We take impression from the implant level. You can see that we have a connected special abutment for impression taking, and using the technique of a snap in order to make it easy to take the impression. And after we have the final working model, we have a setup of teeth. And according to the setup of teeth, we have to correct the angulation of the screw retained restoration. In some implants have a good position, so we use the straight multi-unit abutment. In other case, in other implant, we have some angulation. So in order to have all the access points lingually enough, we need to use the angulated multi-unit abutments. The angulated multi-unit abutments can make it easy to make screw-retained restoration and without losing any of the aesthetic result. So we can change the entrance of the screw from the buccal side to the lingual side, that we can make screw-retained restoration without making any aesthetic compromise. For the straight implants, we can use the straight multi-unit abutment that can also raise the height of the restoration to the maintenance area, and it will be much easier to maintain these cases when we have screw-retained restorations. The shape of the multi-unit abutment can also positively influence the soft tissue arrangement, and will decrease the amount of resorption around the implants. Back to the case, we have selected angulated and straight multi-unit abutments. Now all the opening area is inside the occlusal table of the maxilla, and in this area we can connect the multi-unit abutments, and finally we can check the metal frame. You can see that we have a passive fit, so it's very important to see that we have passive fit of the metal, because there's no cement. The screw-retained restoration has to be as passive as possible in order to have a good long-term stability of the work. And this is the final restoration. All the openings of the screws inside the occlusal table, because we use angulated multi-unit abutments, especially in the anterior aesthetic area. Another case, treating limited height of occlusion because of bruxism of the patient, and one implant was positioned buccally because of the nerve, or the mental nerve. In order to cope with this problem of the angulation of the implant, we can first connect the multi-unit abutments, the angulated multi-unit abutments, in order to correct the angulation of the screw axis, and then we make impression from the abutment level. So first we connect the abutment, we make the correction of the angulation of the implant, and then we take impression from the abutment level. For the straight implants, we can take impression from the implant level. This is the old angulation of the implant. After the connection of the abutment, we have straight angulation. We have the straight access to the screw, taking the impression using the closed and open technique from the implant and abutment level. And this is the final restoration. The final restoration actually is screw-retained restoration. We can use for the abutment of the multi-unit, we can use the adhesive coping for the connection of the zirconium element to the multi-unit abutment, and for the implant level connection, we can use the flat connection of abutment for screw-retained restorations. This is the way of making the restoration. We can make a combination of abutment and implant level restoration. It depends on the angulation and height of the implants. And this is the final restoration. This is the abutment. These are the implant level, and we can make the screw-retained without any problem of insertion pathway or pathway of insertion. And after the connection of the restoration, we can block these openings with composite, and this will be a very good result of the case. So to summarize this lecture, actually the good abutment selection has a very major role on prosthetic outcome, and the anatomical shape, soft tissue stability, and restoration durability is actually influenced by the shape of the abutment and by the selection of the connection, which has the very good advantage for the screw-retained restoration. So I wanted to thank you for joining us for this lecture, and I hope to see you again in another sessions sponsored by Alpha Biotech. Thank you very much.